You could call it for heart problems. The monitor goes on. Regular, narrow, fast, and everyone immediately says SVT. Sometimes it is, sometimes it isn't. Today's scenario is simple, but the thinking behind it is what separates technicians from clinicians. Let me explain regular, narrow tachycardias for you. I'm Angry Bill, and this is Pre-Hospital Wisdom. I've been a paramedic long enough to have made most of the mistakes you're trying to avoid. And I've watched bad habits get passed down like they're traditional. This channel doesn't exist to tell you what to do or how your service wants it done. It's to sharpen how you think, to question your assumptions, to understand the physiology, and to make better decisions when the algorithm runs out. This is part of a series of pre-hospital scenarios that lead to discussions and lessons. I hate when social media shows me a cool EKG or X-ray and then I never see the answer. So I'm not going to do that to you. I'll give you some story, pause for you to consider, and then we can discuss. So for dispatch, 46-year-old male tachycardia. He's dizzy, feels like he might pass out, conscious and breathing. You're about 8 minutes away. You arrive on scene to find the patient sitting upright at the kitchen table. He's pink and dry, alert, anxious, but coherent and attentive. He says, "This just started out of nowhere." So you do your initial assessment. The airway's patent, breathing slightly tachypnic, but adequate. His circulation, radial pulses are rapid and regular, like too rapid to count. His heart rate, 190, regular. Blood pressure, 96/62. Respiratory rate's a little tachypnic at 22. He's sat in 98% on room air. His skin is pretty normal, not pale or anything. So the 12 lead goes on. While it's happening, you get a history and brief physical exam. The patient became dizzy right as his smartwatch notified him that he had a high heart rate. You know those calls, right? He has no chest discomfort, hasn't fainted, and has never had this happen to him before. He's just dizzy and anxious with an angry watch. Your partner hands the EKG to you. So let's pause here for a second. What do you see? Take a look. The answer and discussion is coming in 3, 2, 1. My method for interpretation only needs the first few points to come up with what's going on here. The rate's 190. 4 rhythm questions are there P waves? Not that I can see. QRS wide or narrow? It's narrow. Regular or irregular? It's regular. Is there any extra beats, pauses, or weirdness? Nope, just the rate. If you feel a strong need to work through the rest of the algorithm, the rest of the interpretation, there's no intervals to worry about at this rate. Axis is normal. Chamber enlargement, not the problem. Who cares? Infarct and ischemia, use caution interpreting J points and ST segments at rates this abnormal. The rate itself can cause the appearance of depression or elevation without there being ischemia and such. Don't worry about ST changes until the rate is under 120 or 130 as a general rule. In this situation, the problem is the rate. Hopefully you got that pretty much immediately. What is regular? 190 with narrow QRSs. Well, there's a list for that. Here's the teaching moment for you. Regular, narrow, complex tachycardia in adults is essentially always one of 3 things. The list is sinus tachycardia, 2-to-1 atrial flutter, and paroxysmal supraventricular tachycardia. That's SVT or PSVT. That's it. Irregular is a different list of possibilities, by the way. So the regularity decision is important. Fold the EKG over to see if the QRSs line up. The other cheat is to look at the heart rate on the monitor. If it doesn't change or vary, it's regular. That number up at the top left corner is what I'm talking about. So let's break the 3 options down. Sinus tachycardia. What defines it? P waves before every QRS. Constant PR interval, rate usually less than 160 in supine resting adults. Yes, it can go higher. But if it's 190 and a 46-year-old sitting down at his kitchen table, be skeptical. And what EMS patient is resting? There's always a little excitement just based on your presence. There are people in their house with their names on their butts. Here's an example of fast, but with visible P waves. Sinus tachycardia always has a reason. It's a response to something else, like hypovolemia, sepsis, pain, anxiety, hypoxia, shock, sympathomimetics. Sinus tach doesn't start out of nowhere. It ramps up and it ramps back down. If it flips on like a light switch, that's usually not sinus tach. The clinical pearl. If you're treating sinus tachycardia with adenosine, you've missed the diagnosis. If you can identify the P waves, it's sinus, so seek out what's causing it. The sinus tach is never the problem in and of itself. The second option is 2-to-1 atrial flutter. This one gets missed constantly. The classic rates are that the atrial rate is a rate of 300 with the sawtooth pattern, and 2-to-1 flutter means that there's a ventricular rate of 150. So if you see it regular, narrow, a rate kind of in 140 to 160, that should make you consider 2-to-1 flutter, because that's probably flutter. Look at this one. The flutter waves may be buried and hidden by QRSs and T waves, or they look like TP groups. Is that a T and a fat honking P? Look in inferior leads in V1. Sometimes flipping the EKG upside down like this makes it visible to your eyes. I don't know how that works, but you should try it. I like to do it because it makes partners and patients really uncomfortable. When you stare at a 12 lead, you're looking, you look up at them, shrug, flip it over, and then look at it some more. Look at lead 2 at the top of this. It definitely looks more sawtoothy when it's flipped upside down. And if you land on adenosine for flutter, it doesn't fix it, it just unmasks it. You can slow it briefly so you can see the underlying sawtooth atrial activity. But why do that to them if you don't have to? Adenosine's uncomfortable. A regular narrow tachycardia at a rate near 150, consider flutter, consider it hard. The third option is PSVT, that's AVNRT, AVRT, etc. The hallmarks are sudden onset, sudden termination, very regular, narrow, rate typically 170 to 240, fast enough to be out of the flutter range. Faster than 240 is probably Wolff-Parkinson-White, but that's a different topic. There's often no visible P waves, they're either buried or retrograde. And the patient description in this case is it just started. That's classic. This is SVT. Some experts call it PSVT, paroxysmal supraventricular tachycardia. Paroxysmal is a fancy word that means episodic. Why physicians don't use the word episodic, I don't know. It's called paroxysmal. It just started. But the vernacular in informal settings is SVT. And I switch back and forth between the two terms randomly, so it's going to be fun for you. The mechanism, the term PSVT is a catch-all. It means AV nodal reentry tachycardia, atrioventricular reciprocating tachycardia, atrial tach, 1-to-1 flutter, which is pretty rare, and even extremely fast junctional tachs and sinus tachs, which are too fast to see the P waves. They all end up looking generally the same with the same effects and get the same treatment. So it's all lumped into the term SVT. They're all lumped into the SVT bucket. Most often, it's a reentry loop from within the AV node itself. AVNRT is the most common subtype of SVT. It's the diagnosis of exclusion. You're saying there's no P waves and it's too fast for flutter, too fast for 2-to-1 flutter at least. You exclude the other two options, so you're left with SVT. Back to the scenario. You've got a sudden onset, the rate of 192, it's regular, narrow. Hypotensive at 96 systolic. The patient's symptomatic. So what bucket are you in? It's almost certainly PSVT, not sinus. I can't see P waves. It's not flutter. It's not near 150. And it's not irregular, so it's not a different list. That's disciplined thinking. So what do you want to do for the patient in this scenario? Monitor and transport, medications, therapeutic electricity. Take a quick pause if you like, and the answer is coming in 3, 2, 1. All right, let's do a quick stability check. That's where our decisions come from. He's symptomatic, borderline hypotensive. He's tachypnic and anxious. This is probably a not watch and see situation. The first move is going to be vagal maneuvers. If he's conscious and perfusing, give it a try, but do it correctly. Let me tell you about the modified Valsalva trial from the REVERT trial in Lancet in 2015. You blow into a 10 milliliter syringe for 15 seconds. Remove the plunger and have them blow into the fat end. Say harder, 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 like you can't feel it. Once they take a breath, immediately lay them supine. Follow that with a passive leg raise for 15 seconds. You're raising their legs, not theirs. Not them raising their leg. So the conversion rate is about 43% with that versus 17% with the standard Valsalva, bearing down or whatever. That's not trivial. So adenosine versus cardioversion. Let's talk about adenosine first. If vagal fails, we have other options. Adenosine is a favorite of paramedics. The dose is 12 milligrams rapid IV push in a well-flowing line in the AC at the elbow or closer. Flush hard and fast, either with a saline flush or a blood pump. The efficacy is about 80 to 90% for AVNRT or AVRT. 6 milligrams as an additional dose has slightly lower efficacy. After the first try, your patient may not let you have a second shot. So I say if you're going to be a bear, be a grizzly. The conversion rate is lower for atrial flutter. AHA-ACLS supports this approach, except for they call for 6 milligrams as the initial dose. The clinical pearl, If the adenosine slows it and you see flutter waves, you just diagnosed atrial flutter. The important caveat with adenosine is that caffeine and methylxanthines are adenosine receptor antagonists. That's caffeine, theophylline, stuff like that. They can blunt the effect. So if the patient had like 6 energy drinks and some trucker no-dose pills and whatever else, you might need higher dosing or an alternative strategy. If adenosine fails and the patient remains stable, you got IV diltiazem or IV verapamil. They're kind of like adenosine that takes 20 or 30 minutes without the devil's cold hand gripping the patient's heart. They're effective for atrial flutter, atrial tachycardia, but be cautious. They can cause hypotension, left ventricular dysfunction, and know your patient before you push a calcium channel blocker. Is this patient unstable enough to cardiovert? That's an interesting question. If he drops his pressure further, he becomes altered, has chest pain, signs of shock. Don't overthink it. Cardiovert the patient, synchronized at the appropriate energy, of course. But at the point where he is now, I would probably lean towards adenosine personally. I don't think synchronized cardioversion is necessarily wrong, though. His pressure is rather hypotensive and cardioversion is effective. My thinking is that you would still like to have a line for some periblast benzo love or analgesia. If the line is there, what's the downside of adenosine relative to electrical therapy? They're both uncomfortable. So common pitfalls is calling everything SVT, treating sinus tachycardia itself, missing atrial flutter at around 150, pushing adenosine too slowly, or forgetting to reassess after cardioversion. You want to get a pre and post conversion 12 lead. That last one matters because recurrent episodes may need cardiology referral, and you're showing them what's going on out in the field. Practical field pearls. Regular and narrow with around 150, think flutter. Sudden onset, greater than 170, think SVT. Gradual onset with a clinical stressor, think sinus tach. Always ask what's driving this. Remember the 3 differentials for regular, narrow, tach. It'll streamline your thinking. This entire 10-minute discussion boils down to one mental model. Regular, narrow, complex tachycardia in adults lives in 3 buckets. If you discipline your thinking to that structure, you'll stop guessing. You'll stop over-treating. You'll look calm, and you'll actually be calm. And that's the job. If this kind of structured clinical thinking is helpful to you, stay around. There are a few other EKG discussions on this channel. Thanks for spending a few minutes with me. I'm Angry Bill, and this is Pre-Hospital Wisdom. If this helped your thinking, challenged a habit, or gave you something you'll actually use on shift, do me a favor. Hit like, subscribe, and share it with someone who could use better information as well. That support is what keeps this channel focused on making clinicians sharper, calmer, and harder to fool by bad medicine. I appreciate your time more than you know. Thank you very much.